Hello, my name is Dr. Shanda Blackmon. Welcome to the Baylor College of Medicine Lung Institute podcast series. We're here to communicate with all of our care providers, our learners, and our community, as well as patients, about how to improve lung health, how to educate you and all of the people around you about ways to prevent lung disease, treat lung disease, and maintain lung health. Hello, and welcome to the Baylor College of Medicine Lung Institute on-air podcast. We're so excited to see Dr. Nicola Hanania here. He is our world expert on adult onset asthma, airway disease for children to adults, as well as a wide myriad of problems like COPD, advanced lung disease, and all the other things that happen to people who have uncontrolled disease of the lung when they come to see a pulmonologist. Welcome, Dr. Hanania.
Thank you so much, Dr. Blackmon. It's nice to be here. Thank you for inviting me.
Yeah, it's such an honor to be sitting here with you. Even though I've been at Baylor for about a year, I always look forward to seeing you, and I always hear the best things about you. Your patients just love you.
Thank you.
And I think your colleagues also really enjoy working with you. That's the one thing that I just hear over and over again. You're a bit of a legend.
Thank you so much. I don't know if I deserve all these, but it's a pleasure to be here, pleasure to be at Baylor. This is my 31st year, and
Wow.
I love every year I had, and hopefully God will give me a few more years also to contribute to this noble function that we do every day and treat patients with airway disease.
Well, we need you because we have tons of patients with airway disease. I have a son who's now an adult, and he has asthma. So tell us a little bit about adult asthma and how it's different from asthma in a child.
Yeah, asthma is a common disease. Actually, if I'm in an audience and ask how many have asthma, several hands will. It's about 5 to 8% of the population. Actually, more so in adults, 8% and 6% of kids. But it doesn't spare any age group. So your son is one of the early onset asthma, but we see also late onset asthma. Patients with asthma can present later in life, so it's not restricted to only childhood, and it's a very common disease.
And is it true that children that have asthma can grow out of it as they become an adult?
Unfortunately, this is not true. It's a myth. However, the good news is we can control the disease. We can't cure it, and that's what we're working on, trying to find cure for asthma. We can control it with treatments. We have strategies. There are avoidance triggers and stuff, but we cannot cure it. Once you have asthma, you have asthma. In fact, people have looked at patients with mild asthma who have minimal symptoms. They go down their airway will look different than those who never had asthma. So it's unfortunately not a curable disease, but it's a treatable disease, and it's a controllable disease. That's very important for people to know. We can do something to control it. So
would you say that every adult who has asthma is getting treatment for asthma and is controlling it, or are there a lot of people out there with uncontrolled asthma?
Yeah, so about 50% of patients with asthma have uncontrolled disease if I ask the right questions. And the right question is not how you're doing, how much are you doing? Are you waking up at night? Are you using your rescue medication very often? Have you had an emergency room visit or hospital admission? So about 50% are uncontrolled, but another 50% are usually controlled, and they may have mild disease that they may not need treatment every day, pharmacologic treatment. There is a lifestyle change that is needed for any asthma patients. So it's not just the medication, it's also changes in the environment and the exposure that they have to adopt. Back to the uncontrolled asthma, not all these patients have severe disease. Mm-hmm. Most of people who have uncontrolled asthma, it's because they're not doing lifestyle changes, exposure avoidance, where they're not taking their inhaler as they should. They're not using the inhaler correctly. So all these things are things that we check off when we see somebody with uncontrolled asthma.
And I know from caring for a child with asthma who's now an adult, there's always the asthma airway action plan. Mm-hmm. And it's the prescription for how you're to go from medication to medication, mm-hmm. how you escalate. Is that sort of the central piece of information that you use to guide patients every time?
Sure. It's a partnership. Actually, we can't treat asthma as just physicians. It actually takes a team of people to treat asthma. Not only team of the medical folks, but also at home. And when it comes to a child, it's the caregiver. When it comes to an elderly, I see lots of elderly patients with asthma. I have to deal with the caregiver. Some of these elderly don't know how to use their inhaler. We have to teach the person taking care of them. It's a partnership that we build up. Action plan is part of that. Action plan is part of the education that is needed for patients with any chronic disease. We build up a plan for him or her to use in case they get in trouble. And sometimes we build it based on a peak flow meter that they can use to measure their lung function at home. But sometimes we build it based on symptoms. And we use the traffic light. I don't know if your son got that at one time, but we use
green,
the traffic
yellow, red.
Exactly.
Yeah.
So if we know what their personal best peak flow is, and if they're in the green, then they're good. If they're in the yellow, they need to escalate, mostly the dose of inhaled steroids. If they're in the red, they need to call us or go seek some help.
Yeah.
So we use that algorithm. We tend to use action plans mostly in those with uncontrolled disease. Most people who have controlled asthma are dealt with in the primary care setting, and that's good enough.
Yeah.
I mean, as pulmonologists or allergists, we only see the tip of the iceberg, those really sick patients, because there are 26 million Americans with asthma. We can't see them all in our specialty clinics.
Right.
Majority are seen by primary care.
Okay. But then the primary care provider might get frustrated because they have a patient that's particularly difficult.
Yeah.
Or maybe, I mean, how many of the patients do you think have reflux? And that reflux is really triggering that laryngeal inflammation and maybe setting off their asthma.
Yeah, no, I think you're bringing a very important point, comorbidities. Asthma doesn't live in a vacuum, and actually most my asthmatics have other things going on. Reflux is one, and actually it could be hidden, it could be silent, so we have to know how to question about it and treat it if it is there. But also upper airway disease. We have a united airway approach to asthma, so if we treat the lower airway, we don't deal with the nose, we're not going to get anywhere. So we really concentrate on the nose. Is the nose stuffed up? Do you have allergic rhinitis? Polyps, nasal polyps. We work very closely at Baylor with our ENT docs, with our allergists. So there's a multidisciplinary approach for this disease in more difficult patients with asthma. That's the time of when we get patients referred from our primary care. Those are the ones who have troubling asthma, or sometimes we call them difficult to treat asthma. We go through this algorithm. What are the comorbidities that need? Obesity is a big one in the Houston area. As we know, obesity and asthma, they go hand in hand. They actually don't like each other. Sleep apnea is another big problem, and we have a very good sleep center here. We collaborate with our physicians in the sleep center because sleep apnea and asthma don't get along well. So these are some important things that we look at in patients with uncontrolled disease.
So you're part of a bigger network with your Airway Center of Excellence.
Yes.
And I always, because I take care of patients with cancer, we always hear about the multidisciplinary tumor board, and you'll have the medical oncologist, the radiation oncologist, the surgeon, everyone gathering together. But what you're saying is for these really difficult cases, you have your own board. It's not a tumor board, but an asthma board, and you have sleep medicine specialists, bariatric
GI.
surgeons or bariatric specialists, GI who can help with reflux, ENT surgeons who help with the nasal polyps, and then you and your team
allergists
helping
as
with
well.
the allergy, immunology, all the things that set the asthma off.
That's exactly what I say. It takes a village to manage severe asthma.
Sounds like it.
People think it's just a quick fix. Sometimes it's not, and that's one of the things I communicate with my patient when I first see them. I ask them, what are you expecting from your visit? We set the expectation. We have to.
Yeah.
Because it's a two-way highway. We have to get them involved in their care. So it's a partnership. I set the expectation, but I also tell them this is not a one visit. We may need to see you more than once to get things to know you more and to get you on the right plan. And then, once the asthma is controlled, we see them less often.
And how do you judge how well people are doing? You said sometimes you go by symptoms, sometimes you use a peak flow meter.
Yeah.
Do you do the full pulmonary function
Yeah,
testing or?
so we in the clinic we use questionnaires. There are
Okay.
validated questionnaires. One of them actually something that patients can find on the web, the asthma control test,
Okay.
ACT, www.act.com. They can fill it up. It's a 5-question question. It gives us an idea how symptomatic the patient is.
Okay.
We also like to do physiologic measurement, and that's spirometry, lung function.
Right.
We definitely do it for diagnosis, but we do it after we start treatment to see if there is a response. So it's not just the one thing we look at. Symptoms are important. We look at lung function. We ask about flare-ups. All these together tell us if the patient is doing well or not.
And then sometimes treating the symptoms, treating the cause isn't really enough, and you have to go to extreme measures. What do those extreme measures look like?
Unfortunately, 5 to 10%, and that's a small number of all asthmatics. 5 to 10% have what we call severe asthma, and those patients are problematic. They're nice people, don't get me wrong, but they're problematic because their asthma causes them to be admitted to hospital, go to emergency room. They cost the system 80% of the total healthcare costs because they're high utilizers, but also they miss work, they miss schools. There are lots of indirect costs. These patients, we go in looking at what type of asthma they have. People ask me, what do you mean what type of asthma? Is it asthma is not one face disease? Well, we've learned now that asthma has multiple faces.
Right.
Indeed, we are thinking outside the box now when it comes to asthma, like we are doing with other diseases. There are certain tests that we do to know what type of asthma a patient has. Is it allergic? Is it non-allergic? Is it eosinophilic? There are certain blood cells that we look at. Is it late onset, early onset, obesity-related, smoke-related? 15 to 20% of asthmatics smoke. People
Really?
think, oh, with
That's still
asthma,
so
they don't.
shocking.
So those do not respond well to treatment. So we look at what type of phenotype, what we call phenotype in medicine, they have. And then depending on the biomarker, we escalate therapy. Of course, we want to make sure they're using their inhaler correctly. And now we are in the era of precision medicine. So we have targeted therapies, or what we call biologics. There are 6 of them approved for asthma.
Okay.
So we don't start with biologic right away, but we sort of take a step at a time. But in some of these severe asthma patients who require lots of hospital admission, we look at their biomarker profile, their comorbidities, and then decide which biologics to give them. And then we obviously keep them on the other inhalers as well. So it's not just to replace it. There are certain things that can be implemented other than biologics, environmental exposure. We did have the ability to do bronchial thermoplasty, which is a bronchoscopic approach for asthma. Now it's sort of not as popular as it was before, but this would be like involving a bronchoscopy and exposure of the airway to heat. We did the main study where Baylor was one of the sites where we did that study, but unfortunately, recently, this sort of the enthusiasm has died, so we are not referring people for bronchial thermoplasty anymore.
Okay.
So these are the things we do.
So you do a lot of research in asthma as well
We
with
sure
your
do,
team.
yeah.
Talk to me a little bit about what type of research you do and what you've been finding.
No, we are actually at Baylor, we are part of the Airway Clinical Research Network. This was funded in 1999 and continuously funded till now. So that's about 27 years, right?
That's a long time.
Is it more than 20? I don't know the math now. But we've been funded by the American Lung. Most of our research studies are funded by NIH through ALA. We are 18 centers around the country doing clinical trials, answering questions about asthma. Questions that no other studies can answer, simple questions. Our very first study many years ago was how safe is influenza vaccine in asthma?
Oh, wow.
So people think, oh, I have asthma, I shouldn't take my flu shot. Well, we did the study. We recruited 2,000 patients with asthma in one season, and we looked at safety of flu vaccine. And in fact, we documented that it's fairly safe. And that is what CDC used to implement their guidelines that now asthma patients should receive. This is an example. But we also did studies on new therapies, new biologics. We now are looking at what determines lung health in a young population, 25 to 35 millennials. These are not asthmatics, but we are interested to see what are the factors that determine lung health. We know that we're not this. No person is the same like the other, but
Right.
lung growth is different too.
Yeah.
So some people have slow lung growth. Some people have accelerated decline in lung growth. So we wanted to know what. So this is a type of study we're doing. So most of our clinical trials with the Airway Network involve simple questions that would never have been answered in one site, one center, wouldn't have been answered with industry trials. We also do lots of industry trials.
Okay.
We collaborate a lot with pharma to do clinical trials on new therapies. Many of the new biologics we tested here for many years now, and we continue to do so. So our funding for our Airway Research Center comes from American Lung, NIH, and also industry.
And probably patients out there who are suffering from asthma, who've had the benefit of your treatment, or people out there that care about patients with asthma could donate to help your ACRC to do even more research, even more help for patients who have asthma.
Yeah, we value a lot the patient volunteers. If it wasn't for them, we can't really test hypothesis. We have a very busy research unit, and many patients come from our patient population, but we also advertise for our research studies through networking, through internet, and others.
That's great. Well, I am so privileged to sit with you and learn
It's
more
my
about
pleasure.
learn more about asthma, more about adults with asthma, and all the different types of treatment that are out there. I really appreciate you taking the time
You're
to
welcome.
visit with us, and look forward to visiting with you on another podcast on COPD.
Sure.
And I'm so eager to learn more about all the different things that you do, Dr. Hanania. You've been just a jewel in the crown of Baylor College of Medicine.
Thank
So
you. It's nice to hear. Thank you so much for inviting me. It's a
yeah,
pleasure.
thank you. And thank you for joining us for the Baylor College of Medicine Lung Institute On Air podcast.